terms of locally advanced, we really think of stages 3, and there's 3A and 3B, and there's many, many definitions of 3A and 3B. And I always say it's one of the hardest things actually to teach because of the many different, even though these two groups are sort of stages, there's different the T&M classifications of them. So you can have macroscopic nodal disease, you can have microscopic nodal disease. It can be in the mediastinum on the left or the right, making it T3 and 2 or T3 and 3, and that really changes your stage. So it's a very heterogeneous group of cancers. We've worked over the last 20 years to try to cure them. These are not systemically progressing tumors, so we don't find disease in the liver, the bone, or the brain, and that's why they are stage 3. On the other hand, they're incredibly difficult to actually cure, and so the aim of these tumors are to cure them. And historically, that's been with chemotherapy and radiation. And originally it was through surgery, and we learned that surgery was not the curative treatment. We added radiation upon the surgery, either before or after, and we also learned that maybe that improved it a bit, but that was still not a definitive curative situation. And so the current standard across the world would be to give preoperative chemotherapy radiation followed by surgery. And some centers, do surgery up front, but most of the world does chemotherapy and radiation. And if you give a big enough dose of radiation, you may or may not even need that surgical resection. So that's really, in a very simple terms, where stage 3 disease is. And if we were to think of how many patients we actually cure, when I teach, I say it's 1 in about 3. The truth or the reality is probably 1 in 4. And we handpick those patients, so we don't treat all of our stage 3 disease. We pick those patients with good performance statuses. We pick those patients that can undertake chemotherapy and radiation. And those are the patients that we undergo chemotherapy with radiation to try to attempt a curative resection. So given all that, and given there's really been no really moves forward in the last 5 years, higher doses of radiation doesn't help. Surgery may or may not be important. Chemotherapy, which agents you use, sort of differs across the world. That doesn't seem to be, that meaningful as well. And so here comes the Pacific trial that after that chemotherapy and radiation randomizes patients to an immuno-oncology drug called durvalumab. And that drug is given through the intravenous every 2 weeks for 1 year. And the results were presented at this year's ESMO. And I think they're outstanding. The progression-free survival was 11 months longer in the group that got durvalumab. This was a 2-to-1 randomization in both 3A and 3B. They were pretty well matched for performance status, and 3A versus 3B. And the group that got durvalumab had about a 16th-month improvement, or 16-month overall survival, versus the group that did not get durvalumab, which was about 5. And sitting in the audience, I knew those numbers before I came in, but to look at the actual curves, I thought were outstanding. Now, is that going to translate into an overall survival benefit? And I'm not sure how it cannot. I'm not sure actually even if that's even that important to have a patient in front of me and to say that, their chances of taking after chemotherapy and radiation, getting a drug like durvalumab for a year, that their cancer is not going to grow, or has not a chance of growing for at least 16 months, I think is huge. And I think this should become the standard of care in stage 3 malignancies. And I should say that, the discussant at ESMO he did a great discussion. He did a very historical discussion, but at the end of the day, the message that it should be standard of care was not there. And certainly, I actually feel stronger. I think that this should now become standard of care in patients with stage 3A and 3B, non-small cell lung carcinoma, independent of histology. We've questioned that for the last couple of years. When you give radiation, you sort of open that tumor, to show its neoantigens, and so that, the immune system can, see those, and if it's primed, attack. And that's the whole, there's a whole theory that that's why oligometastases may be curative, that after radiation, your body's your own immune system, given drugs, can actually improve and cure that tumor. So the idea that radiation opens, the environment to these neoantigens so that the immune system can work more efficiently has been there in the last couple of years. And I think this is proof of concept. I think, we were all worried that after radiation there'd be pneumonitis and, immuno-oncology drugs like durvalumab, a PD-L1 inhibitor, might actually increase that. And I think the radiation pneumonitis was actually quite tolerable and small. So I think we learned from ESMO that radiation likely is priming the immune system, that this is probably why it worked. I can't think of any other theory that's even better. These are terribly hard to treat tumors, and to get an 11-month improvement in progression-free survival after chemo rads has to do something with the treatment you gave before it.